much for that kind introduction. And I'd like to begin by saying that, it's great to see the audience here, and I understand that we are slightly at a disadvantage. Either we are keeping you from lunch or you've come from lunch. So I'm just hoping to keep this brief, and my request to the panelists is also let's kind of keep this very engaging and interactive, and we hope to have some time left for questions from the audience. So I'd like to start by stating that ours is a community of practice. At its core, we have an informal group of leaders and participants, who have the passion for this topic, and in this case, it's healthcare. And this energizes the community. So we're fortunate today. In fact, I feel so privileged to be on this stage sharing the dais with such an eclectic group of individuals who are from diverse institutions, diverse and a wealth of experience. So I'd like to quickly jump in, begin with the first question. And maybe this has been discussed, but I felt that we should start with understanding what has been the shift from the pre-pandemic to the post-pandemic scenario. So that's the first line of inquiry. The pandemic was a reality check and a transformational catalyst, accelerating adoption and implementation of newer models of healthcare delivery. It has served as an inflection point for most of us. So in this context, my question to the panelists is, what have been your thoughts? And what's been your experience in addressing the need to create sustainable and future-ready interventions? And Mr. Naveen, I thought I'd begin with you.
Thank you, ma'am. What did we see in the pandemic is the leveling ground. I think that's what do we see in the pandemic is the leveling ground, right? So there was a lot of gaps which are there regionally. If you see the phase one, I would call it the first phase of COVID, the country was unequally distributed across the healthcare. But if you see the playbook for the second wave, which is Delta or the Omicron, Omicron was the best example. Every single state had the same kind of logic, strategy, and management. How did this happen? Within 2 years, the efforts which were taking 60 years, 70 years, our health system's always been there. So I think it was a blessing in disguise, right? That's most important. We should understand pandemic has helped us to strengthen the public healthcare system. I would proudly say that India could respond very well to the pandemic because we had a very strong public healthcare system, whereas US failed because it did not have a strong public healthcare system. And how did we come out of the pandemic? It's because of our strength in pandemic or the public healthcare system. I'll give you a small example. One of my friends, he was telling me, Naveen, when they got sick, there were people coming to his house taking feedback from them whether they are doing well or not. This is the same thing which happens in every village using through ANMs, ASHA workers. The thing is, I keep telling this one, just because we do not see things, we accept that it doesn't happen. Exceptionally, the urban folks like us who are sitting in this hall. Every single day, public healthcare in this country is working, going to doors of the people, asking questions, tracking women, tracking people. In fact, I also have been the PD of APSACs. There are people whom we track whether they are adhering to protocols or not. These are very important lessons we have. In fact, pandemic response was not singular response. There were many examples which we were able to put. Zika outbreak. We had lessons from how we manage things. In fact, Preeti ma'am keeps talking about it. There were a lot of small experiments which came together. In fact, CSR experiments also came together. You remember one of the things which successfully led to pandemic response was the fever survey. Where did this fever survey come from? Every single year, around the month of June, July, August, a person will come to your house to find out whether you are sick or not. This is the malaria program. Did we not use the lessons from the malaria program in COVID management? Yes, we did use. What we learned is all these lessons which we have learned in the past had come together, and even states like UP, Maharashtra, Madhya Pradesh, Andhra Pradesh, when they responded to the Omicron, it was the same. See the mortality figures, see the numbers. Numbers, I'm talking numbers. I'm talking on numbers. I'm not just giving you a gyan on what it would look like, right? These are numbers, they are ready for you to see. That was the biggest leveler in public healthcare. I would see that way. Pre-pandemic, post-pandemic, yes. What is the lessons we take post-pandemic? We need to strengthen our systems because the biggest burden would be NCD care. Our disease burden has shifted to NCD care, 65% to 70. These are the lessons we should adhere to, strengthen our systems, follow up. I think that's also some models, which in fact AP is also looking at family doctor models. These are very important because we have started specializing the public health care. Now it is back to the base of the pyramid. In fact, I'm also happy if somebody wants to work on community pharmacy. I would see the future of healthcare would be family doctors with community pharmacy. This would help in bringing our disease burden in a controlled way. I think we can control disease burden by doing the two things. That's my opening remarks.
Thank you, Mr. Naveen. And Shefali, can I take you up on this question?
Yeah, thank you, Anupama, for this wonderful question. And I partly agree with Naveen ji that yes, with the pandemic, definitely the healthcare system has been forced to, a better state right now. In fact, one of the important positive thing I would say that has come up with the pandemic is that the delivery of healthcare, we are seeing now the technology involved in that. In fact, while going back to the, the start of this topic, the pandemic it definitely had affected most of the sectors, not just the healthcare, but most of the sectors worldwide. And yes, largely impacted the healthcare system because we all would have seen some of the crises that were occurring in the initial state. And which is where the whole role of, the CSR had uplifted, especially the contribution from the corporates and governments supporting this difficult state in India, I would say. And which is where I would talk from the SBI general perspective also that, since pandemic, we have increased our contribution in the healthcare sector or the overall health focus area from 35 to 50% since 2 years, I would say. So that's also one of the vision that we have seen that most of the corporates have also taken as a strategy part. Also to add up here that the core objective of any corporate to support a health focus area is what? Not just to reach out to the community and help the community, but in a way indirectly support the government to reduce the or increase the public service health spends, and at the same time managing or supporting the community to spend lesser from out of the pocket. While this is purely the CSR philosophy that we believe, and which is why we contribute about 35 to 50% of CSR budget in the health focus from SBI general perspective, but it is also our business line philosophy. We are into the business of insurance, which is also a health insurance. Mediclaim is what we provide, and which is what we believe that with insurance we are enabling people to spend less from their pocket for any medical interventions. So that's all from my side. Yes, one of the interesting project that actually came up and we have supported is also the DOSI, which is through the CCAMP NGO. The DOSIs are basically a remote ICU devices that actually were invented and utilized or much in help during the COVID and are also sustainable beyond COVID because that actually helped the hospitals to increase more number of ICUs without any such infrastructure. So any regular bed could also become an ICU because with that DOSI device is what the monitoring device is typically, the doctors could actually monitor the patient sitting in their cabin. So that's one interesting project.
Thank you, Shefali. I think remote care was, one of the biggest things which came about, and focus on telemedicine was something which came about as a result of, the COVID. So Shantanu, can I have your thoughts on, has there been a shift in strategy from, for Save the Children from pre-pandemic to post-pandemic?
Thanks, Anupama. Pre-pandemic, Save the Children, we're a 100-year-old organization and exist for reaching out to the most marginalized children. And largely our program has been, in the primary healthcare system. That was our domain, boundary, and largely software-based program. I mean, not any hardware program, like construction and all those things. So that large programs we manage, technical support to government, behavior change communications, and all those things, what brings change, capacity building. In the pandemic, so we I mean, responding to crisis is in our DNA because we are a humanitarian organization as well, respond across the globe, across the country. Now, the pandemic was unprecedented and we didn't have that kind of preparedness, none of us here. And what Mr. Naveen was speaking, gradually the Omicron time it was, but when it started actually, we didn't have any clue how, but collectively we grew together and we built up. You know, I'll tell one incident. So in Maharashtra and Delhi were the hotspot when it started, both in the first phase as well as the second phase. And so in Pune, we have significant program we do with the municipalities, and in also Delhi. Well, whosoever works with the urban deprived society or the poor, they work with the municipalities, the primary stakeholder they are. And municipalities have the health system. They're not at, I mean, it's a different kind of a management and all. And they usually provide the outpatient care and very minimal inpatient care. Now, they have a health system, they have a health infrastructure, they have operational capacity. They don't have, you know, infrastructure for pediatric care. I mean, if a child gets infected with COVID, and if an adult gets infected COVID, so the treatment protocol, the treatment management, the managing the child inside, I mean, we didn't have any clue how to do. So the Maharashtra government first came up with a pediatric task force. And they invited us. So in Pune, Yerwada, one of the municipality hospital, we developed a pediatric wing for COVID care. Now, we didn't, at that point of time when we were doing that, so our medical expert within the organization and externally, you know, in India, 20% of the children that die as newborn, what do we say, neonatal mortality, it lacks the respiratory care actually, which is a reason. And the primary care health system, what I talk about the municipal hospital or the community health center and all, they lack that critical capacity of providing respiratory care to all those. They usually refer to the district hospital, where the sick newborn care unit, or to the medical college, where the higher level of facilities are available. Now this COVID thing, when we did, and we got into the construction, you know, the infrastructure development, equipment, high value equipment. I mean, in the remotest part, we did it in the tea garden hospitals in Assam. We did it in Kargil, all with the government. We did, not only in urban, we did in Tilak Nagar, in Delhi area. So the experience for us is that, you know, multifolded activities, the pediatric care, particularly when I see from our area of operations, I mean, has been hugely boosted across the country because children's health, it's always a critical problem of a child goes to a superior kind of a thing. So primary healthcare system were not so equipped in the pre-pandemic, the question you're asking. But during pandemic, the response, the category of interventions we did all, I mean, everyone did, they brought that particular focus actually. And eventually that is helping to the entire health system. And now, since there is an infrastructure, training, so they are making it operational for many other problems of the children. So there are specialized units now in the secondary and primary for the children. I mean, that's a huge shift for the system.
Thanks a lot, Shantanu. That was really useful. So, Pratik, I just wanted to understand from the perspective of Malaria No More, have you seen a shift in strategy?
I think, you know, beyond Malaria No More, we're also a very grassroots level NGO. So, you know, this pandemic was an outlier to my mind because we ended up doing cremations. So, you know, that's one extreme of what an on-ground NGO has to end up doing beyond strengthening public infrastructure, providing food and so on and so forth. Why I'm saying it's an outlier because, you know, the way this was tackled, and I agree with Naveen that the public health infrastructure is the one, that's the backbone of the country, and that's how, you know, these systems work. But that, again, was very skewed because the whole system got hijacked. So you had the education system, the Anganwadi system, you name, whatever system was there, everyone was doing COVID. Now, that's not a sustainable option. It's not possible for systems to sustain with just unified action on just one disease. And it was a pandemic of proportions unheard of, and hence all the effort went into that direction. On the malaria front, yes, I mean, we did suffer a lot. Official statistics will tell you that more than 35% reduction in just screening was a stat at the NVDCP site itself. That tells you that, just like any other disease apart from COVID, malaria also suffered. Thankfully, there are not too many deaths happening in malaria, so it just sounds a lot better. It does not sound as dreaded as COVID. But I think that the lessons we take away is that the capacity of the country to respond to a crisis is amazing. So you have the same DGCI who can take years and years not to give a license to any drug or a simple drug. But if the PMO wants it, if the health system wants it, you can have phase 3 drugs rolled out in the country. So the country can really do wonders. We in our, coming back to the malaria program itself, there's a simple concept called long-lasting insecticide nets. We are still procuring the phase 1 of those nets that were developed 10, 15 years back. We have the third phase of that all across the world, but not in India because of procurement challenges and regulatory challenges and so on. So 2 lessons that I think are of vital importance. The fact that we could digitize COVID cases like literally overnight. So you could detect hotspots and everybody was reporting. Of course, there was a huge infrastructure behind it. But the fact is that if there is intent, we could do that. We could do it for other diseases as well. And then we could have actually regulatory, bottlenecks minimized like nothing if there is good intent. And today, a lot of diseases suffer because of regulatory bottlenecks. You have competing lobbies, competing pharma lobbies, and so on and so forth, which is creating a mess. And I worked in the health ministry for a few years also to have a good insight as to how that world works. The country can do much, much better. We are better equipped, but again, I mean, because we work mainly in the east of India, northeast, east, and so on. The quacks saved more lives than the hospitals. You had tons of them under a neem tree with a saline drip, and lives being saved. That's also a fact because you have a sub-center where there's no brick wall. So what are you expecting there? So of course, Naveen comes from a privileged state, if I can say. So I'm talking about Bihar, Jharkhand, and all. Yeah. So so UP examples would be very extreme, especially Eastern UP. So it's a mixed bag of what COVID has given us, but I see a lot of optimism here. Of course, there's been increase in health allocation. Corporates have stepped forward, but I just hope and pray that it gets sustained. It does not become an epidemic response, but just becomes a more calculated and sustained response.
Thank you so much, Pratik. Moving on from the shift in strategy as a result of the pandemic to understanding contextual strategies. There is no one-size-fit-all kind of a strategy, and most of the panelists here have flagship programs across states, pan-India. And therefore, I'd like to begin with you, Kavita. I wanted to understand what has been, does Sanofi have some kind of a contextual strategy in place? Like, because you have a large diabetes program also. But what has been your experience?
Thank you, Anupama. So, I think whenever we start building any flagship program, and when we say flagship, these are not short-term, these are not 3 years, 5 years programs. These programs, we expect them to be for at least 10, 15 years or even more. And that's when you see the impact. When we were building the diabetes program and we went to the board, of course you do the need assessment and you build the program. It takes 8 months, 10 months to put it in place, and then you start implementation. With our program, and I would give you an example about our type 1 program. So type 1 diabetes is very different from type 2 diabetes in the management. So when we started, we felt that the need was to create a network of doctors, a network for patients where they can get a standardized care. There were only 75 centers across India who treat type 1 because it is very time-intensive, labor-consuming. So when we started, there is something else in the ecosystem for the type 1, that is a diabetes educator. Yeah. Now, there are no I will not say no, but there are very few type 1 educators in the country because the management of type 1 is vastly different from type 2. You need to spend hours with the patient because the patient's journey is from a child to an adult. So at different milestones, you need different counseling. And that's when we realized from ground up that there aren't educators for type 1. There aren't qualified nutritionists or MSWs at the ground level where we are operating. And then there came a shift. And we said, okay, fine, now we need to create type 1 educators. I think that is the need. And then we reached out to the parents, the type 1 patients themselves, who became the type 1 educators. And today we are looking at 1,000 educators. But again, the challenges from the ground are that there is no accessibility there. People are not able to come for the education, for the upgradation, for the skill building. So now we are going on a portal which gives us an opportunity to reach wider. So the target with which we began with 1,000 educators, we surely will be able to do 10 times more with that. So I think these are the small experiences from the ground, and everybody would be having them, that as you go along, you tweak the programs and you make change. So strategy need not be what you set out with, but it does change.
Thanks, Kavita. And so, Naveen, I was thinking it'd be interesting to understand, that at a government level, when you roll out programs, do you have these kind of pivots in mind? Like, do you face challenges, within a state itself, rolling it out, any kind of, for example, you have a large comprehensive cancer program that you intend to roll out. There's the Nat Health initiative, but has there been any context-specific strategy that you've kind of undertaken or you've, experienced?
See, I was telling this, I think I was literally ragged in a bio design program last week. So they were telling me, so there is technology available in the state. Why is it the other state not doing it? So there are best practices in one state, we do not follow them. That's where you talk about private also. I remember talking to Devi Shetty, he was telling me I can do this, e-hospital in my Bangalore hospital, not in Shimoga. But Gurgaon, it was successful without doing anything. We always have this behavioral changes which we have to talk about. When it comes to healthcare, there is always this thing, it's because it's a specialized knowledge. I remember when we started doing this comprehensive cancer care, I had 2 radiation oncologists helping me through. So my entire project was looking like LINAC. So we forgot completely about preventive care, palliative care, the rehab part, the pain part. So it means, I think think tanks like this, we also look at Nat Health, which is also in healthcare, conglomerate or an aggregation of healthcare players, which would bring in together this thinking part. In fact, there are technology. In fact, we have used DOSI. She was talking about DOSI. We have around 120 beds in AP which are DOSI. DOSI is that pre-ICU. Instead of putting that person on ICU bed, it will tell you that whether this person would need ICU or not. And it was also good for post-op, after your operation. So it's a very simple technology. It's a 100-year-old technology. It's a simple bed which just picks. This would work because there was an AI ML connected to it, which means we have gaps in the HR system, the gaps in the infrastructure, the gaps in the, we can put medicines, we can put HR, we can put everything, but things would not work. Why would not it work? Because she was talking about telemedicine. We would use digital technology as the last mile enabler. I'm using this word, last mile enabler. Telemedicine is one. There are examples, DOSI is one. So these are technologies which should come, which would change this entire game, which I think fever survey, we were able to do it on a tab. We used to give the tabs to the volunteers, on the ANMs would go house to house. This would mean that data is the one which is driving this healthcare. I think public healthcare, when he was talking about the fever surveys, earlier the fever surveys would be on paper. Now you have these numbers, the phone numbers are there. What we did in AP was tele-triaging. I would call it tele-triaging. It's my own, naming the system. We would go to the house. We would find out whether this person would need home isolation or CCC, the COVID care center, or the hospital. That way we were able to do, what is COVID management? Is logistic management. The rush was running to the tertiary hospital, loading there. People who would not need beds would be sitting there. How would you stop them? We were doing tele-triaging. And also we followed up with the home isolation people, with the doctor calling them every alternate day. You need to put the system right. If I'm alone, what if something happens to me? There were people following up with the person. So we were able to bring a system which would work well. In fact, when you see AP after the bifurcation, not many hospitals did not come. We do not have a strong tertiary system in AP. How did we, in fact, if you see the mortality rates in the COVID pandemic, AP has the lowest mortality rates because of the strategies. I think that is more important. These lessons are to be transformed into better things. And he was talking about malaria. I remember when I was Special Secretary Health in UP, there were 200 people who died of malaria also. There are Japanese encephalitis. This is a smaller disease which can be taken care at the primary health level. But what we do is the cases get escalated to the tertiary care as a serious patient. So it is very important that we need to strengthen our primary health care. I think he was talking about it. Put this wisdom there. So what I would call is we have put the hardware there. Because I'm an engineer, I would call that way. We have put the hardware there, but we should also put the software around it, training, capacity building, responding. I think response is very important. The way we respond to the situation, I would call it. We have a beautiful system. I think the systems are overloaded. That's the reason we are not able to deliver the way we think we should deliver. And I think the digital technology would be the gap, the enabler which would fill in these systems and track down. I think I'm very affirmative. I'm a young officer, so I should always be affirmative that we'll have the strongest public healthcare system. We should build, I think people like you are sitting on the forum would also enable us to make a stronger public healthcare system we would be proud of.
Thank you, Naveen. So Shantanu, same for you. That have you witnessed challenges? Because yours is a large program, correct, pan-India, and so have there been pivots, in the same program contextually, within states or across states?
Yeah, one was the platform, then the format and the content. Now, so we realized earlier we used to have a first aid program for children. So wherever we engage with the children, that's a part of a standard thing. If small injury and all those things, how the families can take care of it. Now, this whole mental health and psychosocial care, we didn't have as a system. It was not part of, it's a tertiary care system. So your secondary healthcare system and your primary healthcare system institutionally never talked about the mental health and psychosocial care. Now, this pandemic has shown that there is a great need of it and at the front line. So, in Kashmir, when we engage with the frontline workforce, so they're very shy, how I can talk about all those. But when we started realizing, that what Mr. Naveen was talking, enabling the last mile, so how it makes a difference actually. Initially they were shy, I can't talk about this and all. Then they found probably their work will be much more easier, they will get better access to them. So we created Bal Rakshak Dal at the panchayat level with the frontline force, panchayat, the female panchayat member and others. But COVID was, again, going to a household talking about COVID and all, so there's a huge kind of gap, mental, physical, all kinds of, do gaj ki duri really made a duri actually with people to people. And so then Government of Rajasthan approached us, they want to develop it fast in an institutional mechanism. So we created a helpline, a mental health care helpline with Government of Rajasthan State Commission of Protection of Child Rights. And initially we started getting 1,500 calls. Now, so COVID is over, we are getting 6,000, 7,000 calls per month, and all sorts of mental health challenges they have. They really want, and that actually is helping the government also prioritizing at the primary or secondary healthcare, how they can incorporate mental health care services. And the second example I will give on the food. The large part of the civil society during pandemic response were supporting people with food, with the cooked food and mostly the non-cooked food and the food materials and all. And the Haryana government approached us, and Gurgaon administration, because our office is in Gurgaon, the national office is there. And what we found, so they said who you are going to distribute. One corporate came forward, they approached the government and then the government approached us. There is a corporate, they wants to fund and this, but only in there. So we found that the TB patients, I mean, the nutrition is so important for them, but when you are distributing food during a crisis time, how do you categorize who should be the first recipient actually? Then, I mean, that the children and the families of the commercial sex worker. I mean, again, this whole do gaj ki duri, created literally people that kind of, but they are the most marginalized. How do you do that hard targeting in that way? And the patients in the hospitals and all. So those challenges we faced, but what we mitigated actually, once we accept the challenge and start working around that, then you find what are the solution pathways you are getting. That was amazing, I must say. Thank you.
Thank you, Shantanu. And thank you for bringing up, the need for emphasis on mental health and the most vulnerable, populations who we need to address. So seeing that we have around 14 minutes left, I just thought we'll come to, one of the last queries which I had for the panelists was, and this is something that I've been hearing in the past two panels also, is about SDG 17. Partnership for goals, the role of collaboration, the role of co-creation. And so I hope that, we could discuss the power of partnerships and the inherent challenges also. So, coming to Naveen, what do you feel, in terms of a PPP model, from a government perspective, what is your expectation of either, say, a corporate or an NGO?
See, when you look at CSR funding, right? So I remember when I joined Survey some 15 years back, I always used to remember it is that innovation project which you can take out and small pilots which you can do. But it has changed in the last decade or so. You see large-scale projects happening. What we look at government is, there are things which I can't do, so I'll ask you to do it so that you will help us in understanding whether it will work or not. Because we can't, see, public money should be spent in a prudent way, so you are the guys who can test and see whether this will work or not, because there are a lot of innovations which are happening. I used to have a fund like 50 lakhs when I was a district collector, which I can use, but I don't think that's a big, it's the suitable money, right? So CSRs would help us to understand, like the way she is doing DOSI, it would help us to understand and bring the paradigm shift in thinking whether we can use it or not. That's more important. I always think the way we want COVID is, I won't call it PPP, it's the abused word or the maligned words. I would call it collaboration. I think collaboration is the way forward. And we collaborating together would bring the biggest change which we look on the public healthcare. It's not just me doing it. For the vaccination drive, we were using Paytm, we were using other apps to tell the story. So that's the way forward. I think we also would be the leaders in medical innovation because of the digital health initiatives which are happening. With the access to health records, we will be the leaders in medical innovation. So I would say pharma industry would grow. I think I'm also told if you look at the volume in the country, it's more like a market for each one pharma company only if they plan this one, right? So there are many things which can happen in this country with collaboration.
Thank you, Naveen. Prateek, can I come to you and, from the perspective of Malaria No More, you are strengthening the government schemes. So what has been your experience here?
So malaria is a poor man's disease. So, if you look at the health allocations also, malaria figures very low in terms of just budgetary allocations. And, at the end of the day, we expect the ASHA workers to be doing every other thing, including reproductive child health and about 25 other disease control programs. And then we also do malaria. So what eventually happens is that it gets very driven by the incentives that they get. And the incentive in this case, as per the government norms, is 15 rupees for a test. So obviously, it's a competing interest, and people are supposed to come to your doorstep. So, and I'm talking about Odisha, where we work, Koraput, Malkangiri, a very progressive state, which has put in a lot of internal, as in state-level resources into malaria. So again, despite being that progressive, there's a huge number of challenges there. I go to Bihar, UP, Jharkhand and all, my ASHA workers have not even seen a test kit. So, you're not even testing, they don't even know. I mean, I'm not saying nobody has seen a test kit. It's like a lot of people have not seen a test kit. They don't know how it gets operated. The diluents that kind of get added to it, the reagent, they're in a very bad shape. They're kept in a bad shape. So even if they're getting a positive, what the hell that means is a big question mark. So, if you look at it systematically, there's a huge number of challenges that we have. But just going back to what Naveen was also mentioning, that one of the roles that we as civil society have to, and CSR partners have to kind of end up playing, is to see if there are models for the government to adapt and adopt. Because the government would normally go with a pattern which is tried and tested. And unfortunately, a lot of CSRs also go that route. That, okay, give me a bunch of beneficiaries, this is what we want to do. The panel before us was talking about innovations, but very few CSRs actually step it up to look at innovation, look at modeling, look at possibility of supporting something which can feed into system. They would want an exit clause or a sustainability paragraph from you, but then if you give them a plan that is truly integrated over a period of time, they probably don't have that bandwidth. It's like a one-year thing you want to do and finish it off and move on. So the best way I see is, one, of course, is to work very, very closely with the government. That's a given. Again, that's an openness we need from the internal bureaucracy within the states and the district officials and so on. Sometimes it works, sometimes it does not. Most of the times I have to push my way through, given my old contacts and so on, which is not something possible for most NGOs, and that's where people struggle. And the openness to, one, accept new ideas, new innovations, CSR collaborations and so on, and get to the drawing board where the DMs can actually have time for health. They have 150 things on their agenda. And there's no question of them giving priority as much, unless it's a directive from the bosses or if there's a catastrophe. And I'm talking about the most hardworking DMs here. It's not possible. There's just so much on the plate. So how best do you kind of utilize, scarce resources when it comes to CSRs or good, solid NGO partners is a million-dollar question, and I don't have a one-shot answer on that. But good intent and open doors and a collaborative approach, that's the only thing that can work.
Thank you, Pratik. And Kavita, Shifali, my apologies. I'd have loved to have heard from you all about this, but I don't want to let go of one question, which I wanted to pose specifically to you both coming from corporates, and that's about, the linkage between ESG and CSR. So organizations have been stepping up their sustainability game, and we are setting ambitious targets. CSR is now heavily embedded in CSR goals and in ESG goals, sorry. So have your CSR healthcare strategies seen a shift?
Yes, I think that's the game now, and we've been hearing it, and especially today, the whole day, we have a session on ESG. So at Sanofi, we are continuously chasing the miracles of science to improve the lives of patients. And also, we have this persistent quest to see how we can better the lives of not only the patients, the partners, the communities, but also our people. And I think that together we talk about ESG. And that has led us to align our social impact strategy, our social impact goals into the long-term business goals. I think that is how it works. Also, all of our social impact programs are now across the company value system, wherein everybody, every department in the organization has a role to play, has something to contribute to CSR and the social impact strategy. In fact, we understand our responsibility, and now we have renewed our commitment to the United Nations Global Compact and its principles. So our ambition for health, and coming as a healthcare company, so for our ambition for health is to improve access to healthcare. And that is not done only by the CSR department, but like I said, everybody has a role to play. And that is the shift, and that is the mindset. In fact, we are creating leaders to citizens. So there is a program where all the leaders have to take it in their KRA and then, drive it as citizens.
Yeah, considering the paucity of time, I'll keep it very short. Yes, certainly the ESG has been the topic in the all boardrooms, and which is where also the CSR is taking it very seriously. To be very honest, from our side, while till now we used to consider and showcase to the board that with these projects, these are the SDGs out of the 17 is what we are aligning. Now it is also the chart that we show that ESG, these are the ESGs that how we are contributing in terms of the percentage. And definitely, while we have these focus areas, but considering ESG, we are also putting a certain amount, a percentage of the funds for the environment projects. And that's a change that I can